Sir, how are you, sir?
I'm fine.
Nice to see you, sir. Nice to see you.
Hello. Hello, good evening. Hello.
Sir, you're audible, sir. You're audible, sir. You're audible.
Okay, good evening. Hi, Bhavna. I can see Dr.
Hi, sir.
Vishwas.
Finally, my heart was skipping a beat because I couldn't see you here.
No,
Dr. Usha,
it's
we are live.
2:59.
We are live, sir. Dr. Usha, you can stop share, please.
Is my slide visible?
Yes,
Yes.
doctor.
Yes.
We are live, so we'll start.
Good afternoon, Natarajan, sir.
Yeah, okay. So good evening, good evening, everybody. I'll just share my screen. Thank Bhavana for starting this. Where is that? You can see my screen?
Yes, sir.
Okay. So thanks to Dr. Bhavana Chawla for starting the retinoblastoma all about the globe. So we had this Eye Cancer Society of India. We had an inaugural session at the AOS midterm conference in Patna, and we inaugurated on 7th January 2023. We had Dr. Vishwas along with us, and today, 15th February, was the International Childhood Cancer Day, which is a global collaborative campaign to raise awareness about childhood cancer and to express support for children and adolescents with cancer, the survivors and their families. And we all know this, so it can be life-threatening, and the whole seminar is for that. And so all this, I think you people are going to talk. So we want from Eye Cancer Society of India to see where the issues faced by children with cancer and their families, and a fight against eye tumors, ocular melanoma, and other eye cancer diseases is what we want. And with this, I request Dr. Bhavana to take over, and I'm glad that I'm leading this Eye Cancer Society of India, and we have all the experts. We have Dr. Jyoti. Both of us were trained together, but I'm happy Jyoti is here, and I keep watching Kung Fu Panda, and I keep remembering JB. Over to you, Bhavana.
Thank you, sir. A very good afternoon to all of you here. And it's really a great honor and pleasure to welcome you. So we just now want to start this, and the whole idea of having this webinar is to promote awareness about retinoblastoma, which is the most common childhood cancer that we as ophthalmologists encounter. So we would, over the next 1 hour, we would like to see what are the issues that are addressing our country and how as a community as a whole we can make a difference to the children who are suffering from retinoblastoma. So we are joined by very eminent speakers today. We have Dr. Ashwin Reddy. He is the clinical lead for retinoblastoma at the Royal London Hospital and also an honorary consultant at the Moorfields Eye Hospital. Our next speaker is Professor Jyotirmay Biswas, who is leading the Uveitis and Ocular Pathology Service at Shankar Nethralaya. We're also joined in by Professor Praveen Vashish. He's head of Community Ophthalmology Services at the RP Center for Ophthalmic Sciences, AIMS, New Delhi, and by Professor Usha Singh, who is heading the Oculoplasty and Ocular Oncology Services at PGI Chandigarh. So I'm really excited to hear them all, and we're also joined by a very distinguished of experts. So let's get going with our first talk, which is all about RB awareness in the UK. And it is my pleasure and honor to invite Ashwin for the first talk.
Thank you, Bhavna. Can you see my slides?
Yes, we can.
Okay, excellent. Thank you. So thank you for inviting me regarding this very important topic. It's a subject close to my heart, and I've been involved with this for about 20 years. Obviously, I'm from the UK, so it's UK based, but I actually did come to India a few years ago, well, a couple of decades ago. And in the UK at that time, we were using this poster, and I work very closely with the group here, which is the Childhood Eye Cancer Trust. So that was a patient support group for families with retinoblastoma. So patient support is quite important as well, because these families, they realize that there's been an issue. They may have had delay in diagnosis, and they don't want other families and other children to go through this. So this is with Santosh Honavar at LVP in 2005. I also visited SN. This is after my fellowship in Toronto. So this is nearly about 20 years ago. And I was coming back to London for my consultant job, and I just wanted to see what was going on in India at the time. And what Santosh was struck by was there weren't many awareness campaigns in the south of India at that time. There may have been some in the north in the early 2000s, but there weren't many. And we discussed awareness campaigns being very important for retinoblastoma care. So working with the group I know very well, which is this Childhood Eye Cancer Trust in the UK and LVPI, we set up the first Telugu awareness campaign regarding the white reflex. And it's interesting and relevant because obviously my heritage is from South India, from Telangana. And in these villages, my family would tell me that having a squint was considered good luck, but not such good luck if it was due to retinoblastoma. So there was something culturally that we had to work on. So what happens in the UK? So in the UK, on a public health basis, every baby that's born has a test. I would call it red reflex test. We'll say why that's probably not the best in the UK at the moment. At birth and at 6 weeks. So that is in our public health protocols. But when children come after 6 weeks, or babies come after 6 weeks, they may still have retinoblastoma, as all retinoblastoma surgeons know. So this birth and 6 weeks is really based on cataract. So the white reflex, the glow, can also be related to cataract. But retinoblastoma can come after this. And I had a child who lived very close to my hospital in London, whose GP, which is a family practitioner, and pediatrician didn't do the red reflex. So I started sending posters out, educational posters. So we audited our results. And from 2005 and 2006, we had no referrals with an abnormal reflex, which doesn't make sense. So then we sent out the posters, and then suddenly we started to get referrals. So out of over 1,500 patients, we had 20 referrals, with 86% being normal. So this is what you'll find, a lot of normals with the abnormal reflex test. We had some kids with cataracts and some with high stigmatism, both very important. So 14% with a disorder, but the pickup rate is low. So you need to have a system which allows for this. And this actually is my daughter, and you can see different reflexes when she was a small baby. She's 16 years old now. And you can't just say, oh, that's normal, I won't worry about it. I dilated her and she was fine. But unfortunately, this testing, red reflex, fundal reflex testing, is the only test we have to get these kids in. So you can see here a tumor at the back of the eye, this dilated pupil, and you can see that white glow, that reflex there. So in the UK now, because I work in London, we have people from all over the world, whereas in India, you probably just have a very homogeneous group. We call this the red reflex test, but actually it should be actually called a fundal reflex, because in South Asians, it can be quite orangey, and in blacks, it can be even lighter than that. So we get a lot of referrals regarding this. So we're now starting to call it a fundal reflex, not a red reflex. So how about this thing, delay in diagnosis, which is a big deal because, and I'll explain why. So we looked at our lag time. So we call it lag time from symptoms to diagnosis in the 90s. And these are my colleagues, Judith Kingston and John Hungerford, who sadly passed. but they looked at it and it was 56 days. So I wanted to see if that's still the case in the 2000s. And it had reduced from about 2 months to about 1 month. But interestingly, still a lot of doctors weren't aware of this fundal reflex and the importance of it. And the reason we got such a short period of time is because 30%, about a third, went straight to A&E. And why did they go straight to A&E? Because of the public awareness campaigns that have been led by the Childhood Eye Cancer Trust, the patient support group. So it has improved, but interestingly, it's the families now are advocates for their children. They know it's important. They're not going to listen to any doctor. They go straight to A&E and say, there's a white reflex. And the A&E doctors know that's important. So how long have we got? Well, essentially, you've got to see these kids within 6 months. Earlier is better, but I'll explain why 6 months is crucial. So studies in Brazil show that if the median time was 10 months, now remember in the UK, it's 1 month, you had metastatic disease, a lot of metastatic disease. In China, if they looked at extraocular disease, it had to be greater than 6 months. This is the lag time, so from symptoms to diagnosis. And once it gets under 6 months, the correlation isn't so strong. So 6 months is where you have to aim for. This is a fantastic paper from Honduras. So what they did is before posters, so basically when your baby had a vaccination, they go to a vaccination center, and then they have a big poster there that's all about the fundal reflex, the red reflex, why it's important. So before the posters, they found that extraocular disease was happening in about 70% of cases, which is a huge number. And look at the lag time, over 6 months, 7 months. And then after the posters, they reduced that by half, this extraocular disease. And as we know, extraocular disease was an increased risk of metastasis and death. And the lag time is now under 6 months. So that 6 months is crucial. That's what everyone should be aiming for. We've also looked at socioeconomic status and ethnicity in the UK. We have the National Health Service. So unlike the States, we don't have any ethnic groups that are particularly relevant to retinoblastoma, or even lower socioeconomic status, because it seems to be a level playing field. In the States, Hispanics are said to have increased risk of delaying diagnosis and therefore having advanced retinoblastoma. We mustn't forget squint or strabismus as a presenting sign in retinoblastoma. And we published this recently, and we found about a third of our patients have a squint. It might have a white reflex and a squint. So what we try and get to GPs, tell GPs, or any pediatrician, is any child with a squint, before saying, oh, it's just a squint, you should see an ophthalmologist in due course, you should always do this fundal reflex test. So finally, this thing around my neck, which you can see here, is an ophthalmoscope, okay? It's called an arc light, and which you can see there. And it's much cheaper than all the ophthalmoscopes you can buy from America and everywhere else around the world. It's solar powered, quite good in India, where you've got a lot of sunshine, not so good in London, where it's always dark and miserable. So solar powered, and it's you can do a very good red reflex test or fundal reflex test using it. And I work in low-income countries in Africa quite a bit. And the purpose of the funding is to improve care in much lower income countries where retinoblastoma care isn't as great as, say, in India. So this is what we recommend for all our medical students. I teach medical students, GPs, pediatricians, everyone who does eye, is involved with the eye. We ask them to put this around their neck, because if they do it put it around their neck, they're more likely to use it, and therefore they're more likely to see what's normal and what's abnormal. So that's the end of the talk. This is the group, the patient support group, which is really important for retinoblastoma, any cancer really. And thank you for your interest. I'll stop share.
Excellent talk, Dr. Ashwin. Always impressive as usual, all the work that you've been doing, and lots of lessons to learn from. You know, as a developing country, I think there are a lot of cues that we can take from you. You highlighted the importance of patient support groups. So I would like to bring in our panelists here today. And Dr. Jolly, ma'am, how do you think this happening in India, you know, engaging patient support groups to sort of advocate for early diagnosis of retinoblastoma?
I'm really impressed with Dr. Ashwin's talk, and it is an incentive that we should be following this. I have already noted, and I think we should do it in our pediatric OPDs and our pediatric wards, where the patients, the newborn are there. And it's though most of the patients which we come across are the ones who already have a red reflex, already have a leukocoria, and sometimes they have even extraocular spread. And by the time from the village they come to us, and from here we send them to RP center, a lot of time is lost, and most of them land up with not having any vision. And we have also seen patients who come with secondary malignancy, who have been treated before, and it is all lack of awareness in the society which is leading to this. So his red reflex test is really very good, and I think we should all be doing this.
Yeah, great. I would also take this across to Dr. Usha Kim, ma'am. Ma'am, do you have this kind of practice incorporated in your clinical setting?
So what we do normally here is our pediatric clinic, we keep running that video, constantly that video keeps going on. Then the other thing we try to do is we have these vision centers. So we have about 105 vision centers spread across. So through the vision centers which are located in the villages, we are also able to create some awareness. We put up posters and, we keep talking about it. There are some, these health workers who come, who volunteers. These volunteers will also go and spread a little bit of awareness amongst people. So what I have seen is over the past 10 years, the late stage ones have reduced. The late stage ones have reduced, and it's not that very early, but it's not way too advanced as it used to be earlier. This has been my experience here.
So clearly, there's a lot can be done.
Dr. Bhavna, I would like to speak a few words.
Yeah, sure.
Awareness thing. Actually, in Bihar. Yeah. Actually, I am Dr. Sunil from Bihar. So what I want to say is that Bihar has got a lot of retinoblastoma cases, and to the bad luck of the patient, to the bad luck of the state, there is less awareness here. When to visit to the which doctor, because suppose they consult doctor in the periphery, many of them, Dr. Bhavna knows, she had worked in Bihar, many of them don't know much about retinoblastoma. So I think we should have a awareness model more useful for a ignorant place like Bihar, so that patient can be referred in early stages to RP center or whatever places or whatever thing, this thing. So retinoblastoma is very important, the awareness part in Bihar. We should have a model to it. And I think I would discuss with Dr. Bhavna how to do it in Bihar. Yeah.
Yeah, so actually there is a lot of difference in India. There's a lot of disparity. I'm sure the states in South India see less of advanced cases, and what we see in the northern part, Bihar, and also from other states in the north, like we have Dr. Maurya from UP. I'm sure that he also sees a lot of more advanced cases. So yes, there is a disparity in the country, and probably we need to have awareness campaigns that are directed towards more needy states. Do it more aggressively than some of the states that are already doing well. So with that, we move on to our next speaker.
Can I add on another one?
Yeah, we just have this after the next talk because Dr. Biswas has to leave around 3:30. So can we put a question after the next talk? So, Professor Biswas, if you can share your slides, please.
Yeah. Can you see the slide?
No, sir, we can see you. Yes, sir, we can see your slides.
Okay. Okay. So at the outset, I'd like to thank Dr. Bhavna for taking this initiative. And it's really nice that with this initiative, many of the vision of the children and the life can be salvaged. I would like to talk on, I'm a pathologist and doing the retinoblastoma work for last 40 years almost. And what research work we have done at retinoblastoma at Shankan Netra Lab. So as a pathologist, the role of in retinoblastoma diagnosis is to confirm the clinical diagnosis of the retinoblastoma and to identify the extent of the tumor spread and to assess the risk factor for metastasis spreading to the other part of the body, to guide the clinician in the management, what kind of therapy should be given. So we should tell that ophthalmologists, surgeons, that they should remove the long section of the optic nerve, 10 millimeter or more, so that we can see that the extent of the tumor spread to the optic nerve, which is quite crucial. Separate transverse section at the surgical end of the optic nerve we took. And while cutting the globe itself, we can find out that it is a retinoblastoma or not, because they have a typical chalky white mass we see, often friable. There is foci of calcification can be seen, extension on the anterior chamber, uvea, optic nerve, and the orbit can be seen in the advanced stages. There are 5 types of growth pattern. The common type is the endophytic, going towards the vitreous cavity, exophytic, going towards the scleral wall, and diffuse infiltrating, which is rare, which goes along the wall of the eye. And complete spontaneous regression can occur very, very rarely. So when you look at the microscope itself, we can make out that this is retinoblastoma. It's not very difficult to make a diagnosis because there's a basophilic masses, the calcification, which is also picked up by ultrasound, is seen in the histopathology. Light eosinophilic areas in necrosis, multiple dense foci, basophilic foci, calcifications is seen. And these are the differentiation of the retinoblastoma is seen in the 2 types, well differentiated with rosettes and florets, and undifferentiated. This is a flexner intestinal rosette, is a typical floral pattern of the tumor cells, specific for retinoblastoma. Cells arranged around the central clear lumen, like columnar cells are seen, indicating a well-differentiated tumors. There is another form of rosette is called homatite rosette, which is not specific, also seen in the neuroblastoma and medulloblastoma. Here the tumor cells are arranged radially around the central core of neural fibrillin, in contrast to the clear lumen in flexner intestinal type. And rarely we see the florets, whereas the flower bouquet-like aggregates of the tumor cells are seen, and with the bulbous eosinophilic processes projecting to the fenestrated membrane. It's look at flower bouquet. And undifferentiated is the most common, where they see the round or oval cells with hyperchromatic nuclei and scanty cytoplasm with a lot of mitotic figures. What we look into that one in the nowadays is that the choroidal invasion, along with the optic nerve invasions. Choroidal invasion can be seen grossly under microscope, dissecting microscope, or it can be seen under histopathologically, where 3 millimeter or more invasion or full thickness invasion indicates poor prognosis.
And of course, the optic nerve invasion and metastasis at the surgical end of the optic nerve, if it's involved, it indicates that the poor prognosis for the patient and now requires chemotherapy or radiotherapy. Retinoblastoma research, which I like to highlight over that one, we have worked on retinoblastoma and we have published at least 35 articles, which I am personally involved in it. And this is Dr. Mahesh Shanmugam, who is with us in 2005. Dr. Mahesh did a PhD on retinoblastoma with me. And it was retinoblastoma in Indian children, the clinical spectrum and outcome of treatment. We have mammoth study of 491 eyes of 358 patients from a single institute. 50% was unilateral, 50% was bilateral. Interestingly, the mean age of presentation was 26 months, approximately unilateral 31.7 months, which is higher than the Western countries. Bilateral 20.44 months. Commonest presentation was leukocoria. Stage 4 disease was seen in the 68.9% cases, and eye could be salvaged in 9.8% eyes. I won't go into the details of the clinical part of it. We also did the histopathological analysis of 232 eyes with retinoblastoma, and we found commonest dose pattern was endophytic type. Majority of the tumors was poorly differentiated. Choroidal invasion was seen in the 36% eyes, in contrast to that waist 23%. Stage 4 choroidal invasion using Snelling classification was the most common. Optic nerve invasion was seen in 32.3% eyes, which is higher than the Western countries. Orbital, scleral, anterior chamber, and iris invasions were found to be rare. No statistical significant difference was noted in terms of invasiveness between the well-differentiated and undifferentiated tumors. And interestingly, we found retinoblastoma, which is thought to be occurs in the children only, can occur rarely over 20 years of age. We published an article in the Survey of Ophthalmology, retinoblastoma in adults, report of 3 cases. And these 3 cases were 32, 21, and 29 years old, and 25 years old. None was referred as retinoblastoma, all having endophytic tumors with VTSA. FNAB was required in one case for diagnosis, established all required enucleation, and was proven on histopathology. We did with Dr. Mahesh Shanmugam, did that fine needle aspiration biopsy in the diagnosis of intraocular mass lesion. This was done in an adult retinoblastoma patient where yellowish tumor mass was seen in the vitreous cavity, and mass lesion was seen in calcification on ultrasonography. The clinical diagnosis of adult retinoblastoma, to give the treatment to this patient, we did a fine needle aspiration biopsy. Dr. Mahesh did that one using 24 gauge 1.5-inch needle, usually guided. It was guided to a clear corneal wound, the root of the iris, jonules, and vitreous in the tumors. Wound was self-sealing, and the tumor cells were seen as basophilic cohesive cells with hyperchromatic nuclei. So I wanted to highlight some. You know that leukocoria is the commonest presentation, but retinoblastoma can present as panophthalmitis, like this case, where we published this case. CT scan showed calcification. There is extensive necrosis. There is hardly any tumor cells were seen, and this patient was found to be having retinoblastoma. Retinoblastoma can present as orbital cellulitis also, and this is a patient with a severe inflammation of the eye with orbital cellulitis, and there's a huge mass of tumor cells was seen in the ultrasound, and there is the extensive process of the tumor cells was seen with inflammatory cells. Retinoblastoma can present as pseudo-hypopyon. We have got 3 cases, and here you can see the hypopyon in an 8-year-old child, and which ACTAP showed basophilic cohesive cells suggestive of retinoblastoma. It can be present as a phthisis bulbi. This is one case, and this eye was enucleated. Enucleated globe showed thickening of the ocular coats and lot of calcifications and necrosis, but we could see few foci of undifferentiated retinoblastoma cells. So even a phthisis bulbi can have retinoblastoma. Retinoblastoma can present with the CNS symptoms that like diffuse infiltrating retinoblastoma with the central nervous system metastasis, which you have seen. I'm not going into the details of this case because it's an awareness program, but I just wanted to tell you that it can have presentation with the CNS symptoms. And I'm ending with an interesting case. This is an 11-year-old boy, which is not a typical age from retinoblastoma, decreased vision and floaters, systemically stable, immunocompetent, and it made a diagnostic dilemma. The patient presented with the cysts in the VTS and the subretinal space, and this was thought to be of various normal chest X-ray, normal ESR, negative tuberculin test. Serum AC was very much raised. So suspicion of sarcoidosis, pediatric sarcoid was thought. And this is the OCT pictures, subinternal limiting membrane deposits, and on the surface of the internal limiting membrane also the deposits are seen. And the post-serum AC was raised, and the diagnosis was a challenge in this case. So thought of inflammatory primary intraocular tumor, metastatic deposits. So the options was take the MRI brain observation, trial of systemic chemotherapy, VTS biopsy, opinion from the expert, which we took the opinion from the expert, and ultimately went ahead with the VTS biopsy, and VTS biopsy showed round glioma, blind hyperchromatic nuclei, and scanty cytoplasm blue cells, suggestive of retinoblastoma. So this we have published atypical presentation of bilateral retinoblastoma and floaters and subinternal limiting membrane cysts in an 11-year-old Asian Indian male. So basic research we have done quite a bit that I don't want to go in details of it. Dr. Krishna Kumar, he's heading our pathology department, has done several molecular biologic studies like KY67 leveling index, NM23H1, NM23H2 gene product, and CD95 in aggressive retinoblastoma. There are several other works that are done. We have also done some work on the genetics, also very basic genetics, as well as the genetic profiling of retinoblastoma cases. So with this take-home message is that suspect retinoblastoma in children, if they present with the not only leukocoria, panophthalmitis, phthisis bulboides, atopian, orbital cellulitis, etc., identify whether the tumor is extended in the choroid, optic nerve, or outside the sclera. Retinoblastoma can rarely occur in the adults. And this was a saying by Sir William Osler, a great clinician, Canadian clinician, who told, as is our pathology, so is our practice. So this is also true in ophthalmic management, particularly in the tumors. Retinoblastoma not only to be seen clinically, it should be proven histopathologically, and also when required from the cytology. Thank you very much for giving the opportunity. This is my photograph in the young age with Dr. Badrinath. Thank you. I'll stop share.
Thank you, sir, for a brilliant presentation and sharing your 40 years of experience with us. It has been such an enriching talk. I would just, take a couple of questions here for Dr. Biswas. I interrupted Dr. Praveen Mogre. So would you like to come in now with your question?
Yes. It's not a comment. It is thanks to Dr. Biswas that he has been doing so wonderful work, and we all have. Am I audible? Can you listen? My voice is coming?
Yes, sir.
Hello? Sorry. Yeah. Ocular oncology and ocular pathologists, we are definitely seeing interesting people now. And but still, the quality work in ocular pathology, especially in the pathology department, is not there. So I have a thought that is it possible that for retinoblastoma or other ocular oncology pathology samples, there can be some centralized collection system and reporting system, so that there can be some standardization of the reporting. Is it possible at Shankar Netralaya place or at All India Institute place?
Actually, we try to do the teleophthalmic pathology, and with Guwahati, with my student, Dr. Dipankar Das, we did teleophthalmic pathology. They're just making sections, not only retinoblastoma, other cases also, and we can simultaneously seeing that slides and making an various magnifications. Now it has gone more advanced and is easy to make a kind of a diagnosis. But in selected cases only, it is possible, because you need to make scanning the slides completely, and but it can be initial diagnosis can be made whether there is a tumor or not, and this has been done. This has been published in Indian Journal of Pathology and Microbiology, role of telepathology in ophthalmic pathology. It's possible.
Thank you, sir. One more question I would like, if Dr. Mahesh Shanmugam, sir, if you can take this question, like Professor Biswas showed us many atypical cases, and that is very true that many times there is a diagnostic dilemma and we're not able to arrive at a clear-cut clinical diagnosis, whatever we might do for imaging or anything else that we have. So in your practice, do you still resort to investigations like FNAB and vitreous biopsy in these cases that, that we present with a diagnostic dilemma?
Thanks, Dr. Bhavna, for inviting me to this webinar, and also Dr. Biswas for the wonderful presentation. Yes, we used to do this biopsy techniques earlier, but it's quite rare now. So most often with the clinical investigations as well as with the other ancillary investigations like the ultrasound, UBM, as well as MRI, we are able to reach the diagnosis. But on the other hand, we used to be very scared about intervening in an eye or entering an eye with retinoblastoma. But now we have become a little bit more adventurous with all kinds of taking precautions. For instance, a retinal detachment in a one eye child with a retinoblastoma, we do a vitreous surgery as well. Taking precautions with the chemotherapy in the infusion fluid, under cover of systemic chemotherapy, as well as intravitreal chemotherapy. So we do that. Despite all that, yes, we are able to reach the diagnosis in 99.9% of the times without any invasive technique. And sometimes if there is a doubt, I would give probably chemotherapy to see how it responds, and then subsequently take it up for biopsy if it's still inconclusive.
Thank you. So moving on to the next talk that we have today, that is by Dr. Usha Singh. Ma'am, are you ready with your presentation? Oh, Professor Praveen Vashisht has already shared his screen. So talk about this now. Yeah. So, we've always we keep talking about we must improve awareness. We must improve, like our society, people, they lack awareness about retinoblastoma. It's so good in the West, but it's lacking in India. So like there's certain states like Dr. Sunil just said that in Bihar, people don't even know anything about retinoblastoma. So we have Professor Praveen Vashisht, who's the head of community ophthalmology services at RP Center. And he's the best person to guide us as to what should exactly be the strategies that we can follow to improve community awareness in RB. Over to you, sir.
Thank you, Dr. Bhavna. I hope I'm audible.
Yeah, very much. Thank you.
In fact, I'm talking to a group of people who are most dedicated for retinoblastoma, I believe. I know Dr. Bhavna is leading in this area for last, if I'm not around 18 years in RP Center. I as a community ophthalmologist, as a public health expert, I represent, I'm assisting National Program for Control of Blindness. I'm also part of Vision 2020 Right to Sight. We have a huge program, nearly 20 vision centers with us. But probably even at this stage, I feel that retinoblastoma is actually named for hospitals only. It is not in community at all. This is my perception. In fact, when Dr. Bhavna asked me to give some strategies for community awareness, I asked my team members who are working in community in vision centers, are you able to identify retinoblastoma? Are you aware of this reflex, white reflex or not? I must say that it was not a good response by our team members. When I talk about National Program Control of Blindness, probably retinoblastoma is not at all discussed in the program strategies. Well, so this is the scenario which I feel, and I think whether like we need to discuss what we need, what is to be done, and how we can give importance to this disease. As far as incidence of retinoblastoma is concerned, I can definitely say that it is not a major public health problem. The incidence of 1,500 cases per year in India, which is 28 per million under 5 age group. That means I believe the total number of cases are quite less in our country. If I see an entire Delhi, the population of nearly 20 million, we may have total of 50 cases in entire Delhi. So number is less. So involving each and every community members, ASHA worker, health worker, when they don't identify such cases, they find difficult for them. And when eye care is concerned, we mainly talk about visual impairment, blindness, cataract. These diseases are much more common compared to this component. And yeah, this is very important that in Western countries, we have more than 90% survival rate. But we talk about developing countries, the survival rate is very low actually. The reason is that usually there is late diagnosis. We know that people, Dr. Sunil has just mentioned in Bihar, people, they keep staying there in the area. They even fear, they even try to hide such cases. What I have seen in my experience also. And there may be some socio-economic barriers also. The people at the level of primary level, when we talk about multi-purpose health worker, when we talk about health assistants or even health educators, etc., the people who are actually working in the community as far as healthcare is concerned, they are not at all aware about this disease. So when awareness is not there among health workers, probably the very poor referral of such cases in our country. And beside this, we have very limited centers for treatment of retinoblastoma in the country. Everyone, even if somebody is sitting in Bihar, he will just talk about RP center only. So Bihar is so far away from RP center. Why can't we have more centers in the country where facilities are available? And in fact, you need a multidisciplinary approach that is completely lacking in our country.
Sorry to interrupt you, but your slides are not moving. Are you in the slides? Slide share mode?
You're not in slideshow, sir.
Yeah.
It's not visible.
It's visible, but it's not slideshow. So only the first slide was visible.
Let me again try. Is it visible now?
Yes.
And moving also?
Yes, now it's moving.
Yeah, thank you very much. So we need to raise awareness, but it is lacking because there is no actually, people at the community level who can identify the risk factor. We talk about white reflex, there's a sign actually. But beside that, probably there is no other factor by which we can identify this disease. And timely diagnosis is definitely, it is very, very difficult. In fact, Dr. Ashwin Reddy has given this example of Honduras, a small country, and there they have seen a kind of effect of posters in immunization clinic. And because of that, there is a good, better identification of cases at the community level. I believe this is a quite good strategy. If we can reach to the immunization program are there in every country and every place in India. If we can reach that catchment of health workers who are dealing with immunization, and we all know that this disease is basically for under 5 population. So I believe we give measles vaccine at 9 months of age and DPT booster at 1.5 years of age. If at that point of time, we can reach to the health workers and they can educate parents, probably it is an important and good strategy by which we can create awareness about retinoblastoma. In fact, what they feel is that the parents, they are the key actually. They should understand about the disease, and if they know, they actually identify a single, we are saying is white reflex or some abnormality in eye, they should immediately reach to the hospital for treatment. In fact, this is one example in Honduras. Beside this, Brazil and Mexico, there are special campaign for early diagnosis and referral, and they are effective campaign. So we have to look which population is to be taken care and where we have to work. But beside, I am very clear that when we are trying for any program for early diagnosis, we should have treatment facilities available. It's not that you can identify cases and there are no place to refer. That is very important. So proper treatment and multifactorial treatment is needed in case of you. Even eye surgeons are not sufficient. You need onco-ophthalmologists, radiation facilities, chemotherapy facilities. So a lot of things are anesthetists, pathologists, the entire team is needed actually. So we should understand that when we are starting a major initiative, a campaign, an awareness campaign, there is a need that facilities for referral and treatment should be available. And what we feel is that we talk about family history. And the family history is positive, then we can target educating parents and health worker. If family history is negative, then educating parents is sufficient. And in fact, the key agenda is for everywhere, it is to know the glow. The red reflex is normal. And if it is some abnormal reflex is there, as Dr. Reddy has clearly mentioned, then people need to be referred. In fact, Dr. Sumit told me about this app actually, which is now available, which is a computer assisted detector of leukocoria. And if you have photographs in your mobile, this app can actually assess whether it is normal or a red reflex or it's abnormal. I'm not aware of, I have not used this app, but probably if this kind of apps are available, which are AI assisted apps, probably it will be more easy for the people to identify the abnormal eye and refer to the appropriate place. So when we talk about prevention, it is basically 3 levels of prevention. There's a primary prevention, which I talk about, that creating awareness among parents and creating awareness about healthcare workers. I believe there is not much use of creating awareness among teachers because it is of younger, this disease of younger population, under 5 age group. And probably school is not a right area for creating awareness. As far as secondary prevention is concerned, it is early diagnosis and treatment. It is, as I mentioned, early diagnosis is there at hospital level only. And in fact, Dr. Reddy has suggested ArcLight, which is a low-cost ophthalmoscope. I am not sure whether it has been tried in our country. I have seen these ophthalmoscope, but probably it needs a wide publicity and also training of medical doctors, people who are working at the level of primary health centers, community health centers, even at district hospitals. If they can use this arc light and identify children with this abnormal reflexes and refer them to higher level. As far as tertiary prevention is concerned, it is actually the rehabilitation. When the patient has enucleation, then we can actually facilitate prosthetic usage. And I know Dr. Bhavna is trying this a lot in our RP center. So we know that it is not a major public health problem, but what we need is basically a kind of registry program. I know that there was one registry program a few years ago in 2012 to 2016. In the entire program, total 257 cases have been registered. You can understand, I believe there are around 5,000 cases in India and less than 5% are being registered in a 4-year registry program. So we need a better national cancer registry program for retinoblastoma. And I believe RP Center and say Jhajjar, they can definitely take a lead into this program. And we use a term called sentinel surveillance. Sentinel surveillance means we can make the sentinel site, different sentinel all over India, and patient, they can passively report to these sentinel centers. And then we have a national registry where all these sentinel centers, they can report to the national surveillance centers. We have tried this thing under National Program for Control of Blindness for other disease. I believe the same strategy can be used for retinoblastoma also. So to summarize, the key strategies is awareness among parents to know the glow, educating the healthcare workers, mainly working at the primary level. They are the key people who can be sensitized. I have mentioned it that mainly the people working at the immunization clinics, they can be sensitized. Parents can be informed about through posters, through IC material, through TV, all these things. As far as national program is concerned, I was thinking about under which program this is appropriately kept, whether it is in the National Program for Control of Blindness. Definitely it can be there. It's part of the childhood blindness component. National Program for cancers, diabetes, cardiovascular disease and strokes. It is cancer, pediatric cancer, so it can be part of this thing. Maternal and Child Health Program, where we are looking for creating awareness because the biggest program in the country. So creating awareness through MCH program is another component. And probably the most important one is the Rashtriya Bal Swasthya Karyakram, RBSK component. I'm sorry that this disease is not yet registered as part of RBSK. This can be the most important initiative from this group, that like cataract, pediatric cataract, like ROP, RBSK should be part of the, this retinoblastoma should be part of RBSK, and the entire course of treatment should be totally free for this disease. This is one thing which we are looking. In fact, RBSK is part of the district program also, is part of CHC also. So screening at the level of CHP can be conducted under the RBSK program. Probably this is the best input I can give about this group of people who are working for retinoblastoma. And in fact, it is not one or two program. It should be the integrated program for all, integrated approach for all these 4 different programs. That is the actually need of the hour in our country. And I thank you, Dr. Bhavna, for leading. In fact, this is one program, it's International Childhood Cancer Day, which was celebrated here. This is a photograph from there. This is one way of creating awareness in community. It is very important through talks, through awareness walks. And this is one of the good strategies. Thank you. Thank you very much, Dr. Bhavna. Thank you.
Thank you, Dr. Praveen. That was such an excellent presentation. And usually what happens is that we as ophthalmologists just keep hearing each other. And it is so very important for us to hear things from a public health perspective, because this is exactly what is going to make a difference. And this is what we have in mind as we, we move forward, to incorporate this into as one of the major goals of our program, improving awareness. And all the tips that you have shared with us are going to be extremely helpful to us in the years to come. I would just take 2 questions here. For the first, I would like to invite our panelist, Dr. Manavjyoti Burman. He's joined us from Guwahati. Hi, Dr. Manavjyoti. Good to see you here. Is he probably, I'm not sure if he's able to hear us. In the meantime, we can also speak to Dr. Maurya. Dr. Maurya is practicing in Varanasi in UP, and I'm sure he also sees a very high volume of, very advanced cases. So, sir, what do you think is the awareness scenario in UP? And
ma'am, as you told that I'm working in Banaras Hindu University, which is located in eastern UP. And the area is having a low literacy level and very poor socioeconomic condition. Most of our patients are reported in late in advanced stage when the globe salvage and survival is very poor. So we think that people should get more awareness about the early detection, and not only early detection by, as Dr. Praveen said, that the disease is low prevalent in our country. But I think that is retinoblastoma is under-detected, under-reported morbidity. And what we are seeing, that is just top of the iceberg. Because of unawareness, our health worker, like even Netra Sahayak, who is working at primary health center, and also medical officer, Ayurved medical officer, they didn't know what about the retinoblastoma and leukocoria. So there is an important role of health workers they know about the early detection and red glow. And also, I think there is a role of government also to increase a strong referral center, retinoblastoma center with multidisciplinary team, and also to create a retinoblastoma program in any form, either in vision or national blindness control program. So the rural public should be targeted.
Yeah, so actually, it's not that we have not tried, Dr. Praveen, like it's many times. I have personally been to the ministry, and the biggest hurdle that we face is the first question they ask us is how common is it? And the moment you tell them the incidents, they say, oh, well, we can't put our money into this. We have so many other public health issues to take care of, how many children die of retinoblastoma. But I don't know how to break this barrier. So really, that is something that we have been facing with
I
retinoblastoma.
think, ma'am,
I'm
we
sure
should.
if other countries face the same situation. Ashwin, what's your take on that?
Thanks, Bhavna. That was a great talk that was given. So what we have to do, obviously, is join forces with the pediatric cataract and blindness teams, because it's the same screening system, right? So the red reflex test, the fundal reflex test, is relevant for pediatric cataract and for retinoblastoma. So we need, and at least if we can get them in some form of a system early, we have a chance. Then it's really up to the patient support groups, I think, to lobby. You can lobby, but I think they have to lobby. And what you'll have is, in India, you'll have poor people who have retinoblastoma, but you also have rich people who have retinoblastoma. And they can be advocates saying, look, this is the problem we have. You're obviously going to RP or going to SN or somewhere, and we're giving you a great service. But many Indians in India can't access these services. What do you think? And probably it's just trying to increase awareness. And when we're talking about awareness, we shouldn't forget social media as well. If anything happens in the news that is controversial, it's all over social media. We even hear it in England about what's going on in India. So it's just trying to use as much awareness and try and get parents of advocates for you, and just say, yeah, okay, your child might have done very well, but there's lots of children who haven't done well. How can we move that forward? I think it's very, people say it's rare, but in Europe, it's 1 in 13,000, which isn't rare. But I understand in India, you only have a certain amount of money in the healthcare pot, and there are other priorities. So you need to use your patients as advocates as best you can. That's my only suggestion.
Yeah, thank you. That's a great suggestion. So we have, I think, as far as social media is concerned, we should go to one of the, our young panelists here, Puneet. Puneet, so, you guys, this generation is all about social media. So would you like to come in here and comment on how you think social media can make an impact on retinoblastoma awareness? I think he's probably not hearing us. So we can move on now to the next talk of the session, which is very, very important. And it's about the healthcare barriers that we face when we try to, sort of put our treatments in place. And this talk will be given by Professor Usha Singh, who has many, many years of experience in handling retinoblastoma at PGI Chandigarh. So, ma'am, we're excited to hear you.
Good afternoon, everyone. And dear chairperson, friends, and panelists. And thank you, Dr. Bhavna, for giving me this opportunity. So, talking about healthcare barriers would mean to talk about the tumor burden distribution world over, and to understand the healthcare barriers and finding and implementing solutions. My moving. Hello. Okay, so can I go back? Can I go back? My slides are not moving. Hello.
Doctor, can you click on the screen and then it's moving? You can just click on the screen and then.
No, I want to go back.
Yeah, you can go back, my doctor.
How to go back?
Just press the left arrow on the keyboard. Just click on the screen and press the left arrow. Yeah, all good, ma'am.
So I was saying that we need to talk about all these issues, the tumor burden, understanding healthcare barriers, and finding and implementing solutions. My slide has. Are you controlling the slides? Hello, can I go back?
Yes, ma'am, you can. You click on the screen and you can go forward and backward.
But it's jumping slides.
Ma'am, you can just click on the left and right arrows on the keyboard.
I am doing that. But
Yeah, it's going, ma'am.
now the next slide after this gets stuck.
Just do one right.
I did it.
Or you can do it on the screen once you move over the mouse. Just click on the screen. Your screen is getting this thing. Click on the screen.
Oh, okay. Oh.
It's a blank screen now.
Can you give me 2 minutes? I would like to just log out.
Yes, ma'am.
Yeah, please.
Yeah, sure. In the meantime, we can take questions. I think Dr. Sunil and Dr. Mahesh both had a question.
Yeah, Dr. Bhavna, not a question exactly, but Dr. Praveen Vas's talk was very good regarding the awareness, and he talked a few very important points and a take-home message for the society that this thing should be included in RBSK program. I think the society under the leadership of Bhavna can do much for inclusion of that. But he said that it is not much of a public health problem. There is where I disagree. It is a public health problem because it involves infants and kids. And there's so many mandates, and it is very deadly that it can take lives also and functions also. So the seriousness of the matter is not only in numbers, but at age which is with this disease affects, and the severity of the disease. And involving a second thing, like he talked about a very good thing, red reflex test. Yes, it's very handful, but not only that parents should be make aware of it. The Asha Karyakata that we have in Bihar, they go to door. They should be made aware of the red reflex test by the society members, by us. And then they can, when they go door to door for other programs, they can do this by a red reflex test, whether there is leukocoria or not. And then the third thing is Mamta workers. These two things, I don't know about other part of the state, but Bihar has a very strong network of Mamta workers and Asha workers. Asha is ASHA, accredited social health activist. They are involved in many programs. If it's get into RBSK, definitely it will be their job. But even if it's not, we can sensitize the government. And if something is to be done at Bihar government level, I think Bhavna herself is sufficient. We are with her. And if it's national level, and then also she will be very useful in that. And the society should take up two things: that how to introduce awareness about red reflex test in the workers, and second thing, incorporating this thing, retinoblastoma, in RBSK. These two things are the point I want to make. Okay, thank you.
Okay, I'm ready. Can I share my slide? Hello?
Yes, ma'am, sure. Please go ahead.
Please.
Yeah, I would like to share my slides. Just a minute. Yeah, just a second. I have some.
Dr. Mahesh, sir, you had a comment meanwhile?
Yeah, that's right, Dr. Bhavna. I agreed with Dr. Praveen about a lot of points which he made. More than going to the grassroots healthcare workers, even our pediatricians are not sensitized adequately. So most of the time when cases come to us advanced, it's the parents do complain of the squint or white reflex, and the pediatricians actually don't advise them to go to an ophthalmologist. Second is even our own ophthalmologists. So if it's a general care ophthalmologist, if there is a squint, they don't dilate the pupil and see. So the problem starts there. Leave alone the grassroots ASHA workers. Our own brethren who are pediatricians as well as ophthalmologists do not prefer or do not dilate and see. That's where most of the time we see that the patients come to us today. And we should start sensitizing them as well.
May I respond, Dr. Bhavna? Just 1 minute.
Yeah. Yes,
Yeah. In fact, I would mention like about the ASHA involvement in this program for retinoblastoma. In fact, let me remind this group, when I was talking about ASHA workers should be used for eye care program, there was inhibition from ministry that they're mainly for maternal child health program. In eye care, we wanted to involve them for vision screening. There were inhibitions. For cataract identification, cataract they can't identify, so we said blindness identification. So just compare where when the ministry feels that they can't even identify for cataract, how we can involve them into retinoblastoma, red reflex. It is difficult for a 10th class worker who are actually and they want incentive. They are not getting any salary. They are incentive based stuff. It is very difficult that they will say they have screened, and the screening based incentive, it is not feasible for retinoblastoma. This is really difficult actually. But as for Dr. Mahesh has mentioned, the pediatrician, the ophthalmologist, the medical officers, actually these are the people in our entire country who should be involved into this program. Whenever they're examining any patient, they should be able to identify such cases, risk cases for retinoblastoma also. That is something very positive which we should look forward. Thank you very much.
Yeah, I agree with Praveen, but I think as a president of All India, when I went and met the health minister and the health secretary, that time P.T. Sudan was there, and they clearly told me ASHA worker is not for even. When I went for diabetic retinopathy screening, they clearly told me ASHA worker are very busy and we cannot give. Even in Mumbai, they are telling the same. So I am now trying to convince the municipal commissioner, because he's got some 6,300 crore for health budget. So I'm telling him to do something for diabetic retinopathy screening. So I think people, Dr. Titial is not here. Dr. Bhavna Chawla should make an issue with their RP center consultants, and there should be an advocacy like the American Academy of Ophthalmology to go to government. And I think we have to insist to the government, and we have to have powerful people to say what is good for India, and not just whatever the IAS officers and whatever the officers are there who are actually bureaucrats who think they know everything. But I think we have to become like IAS officers in India and think like them. And that's what I'm trying to move. I'm thankful to our BMC commission, who is an IAS officer, who's really understood what I want. Because I think that's why Dr. Bhavana wanted me to be president here. But I think we have to work with the government to find out what is the solution for either ASHA worker or any other cadre of. We have also skill development corporation in India where we have to use them. I'm trying to tell any school dropout should be trained. Why have a Romeo police in UP? I want to address this to UP Chief Minister also, Adi Yogi Adinath, saying that why can't we have these people workers, healthcare workers, rather than a Romeo police? So I think we can talk here in whatever we want, no use. We have to go to the parliament. We have to go to the IAS officers and make them believe. If there some of them want anybody IAS officer children had a retinoblastoma, then they can be the ambassador to convince the government. Otherwise, we will be keep talking. We'll be doing seminar webinars. This is what I'm seeing from 2017 as a vice president to president, and now past president of AOS. I'm now also the ICU office bearer. I think within our own group, we talk, absolutely no use. We have to have leaders like Praveen and Dr. Bhavna here, and Mahesh, what is he saying? We, and probably from Dr. Usha Singh from PGI and Dr. Sunil from PR. I think we have to go. We have Dr. Watts as MP. They are not bothered, I'm telling you. Dr. Watts is our own colleague. He couldn't help me. Even Dr. Vikas Mahatma as MP, he could not talk about eye at all. He took me to the health minister, but they are saying, okay, use the paper and go. Nothing happens. So I'm not frustrated. I'm actually going to make a thing, and one day we'll make the Prime Minister call us and say what we can do for India for eye care.
Thank you, sir. Very encouraging.
Sure, sir. The day will come. The day will come. It's very encouraging, sir. Yes.
Hey, we have to do that. I'm not joking. We have to do that. Prime Minister has to call us and say, what can you do for eye care? Because even in Bombay, I'm seeing the difference. So the Bombay Municipal Corporation is really listening to me. And I'm going to set an example. I even asked for a new thing as an emeritus professor for all the medical colleges in Bombay, just to say that I don't want power, I don't want name. I want to work for the poor people of Mumbai. So we can do that. And Praveen and Bhavana, you're in Delhi, you are in the capital. call us, we'll come. We don't have to do dharna. We don't have to do agitation. I think we have to the word sensitize, I'm happy. We have to, Dr. Mahesh Shanmugam said, we have to knock the door, and we say prayer can move a mountain. Why can't we pray and move these IAS officers and ministers?
Definitely, so today is Mahashivratri and
Yes.
Lord Shiva is
It's my day, no? Mahesh, no, you have Mahesh there and Natarajan here.
Yeah. So nice, no? And that we are doing this on Mahashivratri and we have the blessings of Lord Shiva with us and he's the epitome of power. So we have to look ahead.
And we have a double Usha, no?
Yeah.
I just have one quick comment to make. We were just talking about corneal ulcers with Dr. Srinivasan, and I was so shocked to hear that we are getting 5,000 new corneal ulcers every year just in Madurai alone. So then I asked him, what is happening in what about the awareness? Because he did a lot of work with a lot of people and different contexts. He was doing a lot of work on prevention activities for corneal ulcers. He said that out of the 44 villages around Madurai, 2 quacks are there in every village just to remove foreign bodies. And they believe even the elite, I mean, in the sense, in each of the villages, you'll have some elite people. They would only first go to that person and not to anybody else. So those are the people we should tap, sir.
Yeah, we should
Those
actually.
kind of people are the ones who are actually the ones who are sought after for any health issues.
Yeah, I think so, but we should arrest them.
Yeah, that's, I mean, that you can do what that.
No. In Bombay, you're right, Usha. In Bombay, can you believe, next to KM Hospital, one guy hired a hall. This is about 15 years back. He said, all of you lie down, I will cure blindness. And I don't know what he was putting. Luckily, he didn't spoil the eye. He was putting drops. The fee was 1 coconut. So per day, he was collecting some 500 coconuts. In 5 days, he'll vanish. And then he went like that in 3 places. And luckily, I don't remember who was the ophthalmologist who complained and caught him. He'll just vanish after 5 days. So 5 into whatever number of coconuts he collected in lorry loads and sold it and made money. So I think so. So I think I will give Dr. Madhu Badria's example. Dr. Usha, you were there. I think they told me they also had some 5,000 ulcers because of that sugarcane, that leaf. And finally, I think they have come down to some 5 or per month or something. So I think that's because of luckily there were no quacks and they were able to, any injury they told them to come and their loss of pay was not there. For example, that person who had an injury were allowed to come to the clinic and go back, but with no loss of pay. I think the problem with workers is if they don't go, the people who are employed them as a day-to-day laborer, they don't pay them. And if they don't work one day, you can imagine no food for the children. So that's why I have this roti bag. So Bhardiya said, if you can't give food to one person, Jagatine Alitiduvo. That means why universe should not be there. So I think we have to do something, Usha. And I think we can't be a silent observer. I don't remember where I read. If you're a silent observer, if some crime is happening, you are a criminal. And I think in the Muthu movie says that, I think. And I'm sure we have to do that. And we will work, Usha. You command us, and spiritually we will do something to make sure they are put behind bars, and we also do good to the people, and particularly retinoblastoma, because people can have myths also with squint, lucky and all that, and they don't come. And they finally die.
So true. So that naturally brings us to this topic of healthcare barriers in care of retinoblastoma. Quacks are one such barriers, and we'll hear more about them in the next talk. Ma'am, are you ready, Dr. Usha?
Yeah. Yes. My slides are visible?
Yeah. But you are not visible.
Okay, so we need to know the tumor burden, and as we know, there are nearly 8,000 new cases annually worldwide, and we know it's a curable cancer. Despite advances in medical and surgical treatment, it's complex and challenging task with severe healthcare barriers. And this will impact the quality of care to these affected children and their families. Now, what has been brought forward through the publication is the Global Disparity in Retinoblastoma presentation. Major global retinoblastoma burden lies in the middle income countries, And I don't agree that it is not a major problem. It is a major problem in our country. And as we can see that more than 50% of the cases are reported from Asia. And as we see from these figures that the lower middle income country has a maximum percentage of these cases. And in this study, the disease burden was studied, and the figures are from this study. And another thing is that advanced disease occurs from more in these middle income countries and low income countries. The patients from the low income countries probably they don't survive um, to grow into adulthood. And even the extraocular disease, if we talk of, it is seen in the lower middle income countries, whereas the high income countries, they see 99% of them are intraocular retinoblastoma disease. So survival is the worst in these lower middle income countries. And the independent factors for worse survival are residence in a low income country compared to high income country, and older age at diagnosis in children up to 3 years. Now, there are various issues with these lower middle income countries that the cancer is diagnosed late in children. Their older age is associated with more advanced disease. Smaller proportion give familial history, less familial history of retinoblastoma. And also the retinoblastoma disease from these countries is aggressive. And this is likely due to the prevalent HPV infection in these countries and a high oncogene amplification in unilateral cases has been linked to aggressiveness. So we found we detected HPV in fourth eyes with retinoblastoma in our study. The lack of, so we can just summarize the barriers to healthcare in these categories: the lack of awareness and early diagnosis, treatment abandonment, limited access to specialized care, financial constraints, cultural beliefs and practices. So now coming to the lack of awareness and early diagnosis, this is the biggest barrier in retinoblastoma care, and it's often misdiagnosed as eye infection, etc., leading to delayed treatment and poorer outcome. It's not considered as a serious health issue in certain regions. Therefore, affected children may not receive a diagnosis until the tumor is advanced. The reason is lack of public awareness, limited availability of screening programs and diagnostic tools. In some regions, there are no routine ocular examination is done in children. Hence, RB may not be suspected until patient develops white reflex, vision loss, and strabismus. Now, limited access to specialized care. In many regions, there is shortage of trained healthcare professionals, facilities, and equipments. Many patients remain under observation when they are being referred from one center to another. The parents become confused, which leads to loss of treatment compliance, follow-ups, and ultimately treatment is discontinued. And there are very few multidisciplinary centers which provide retinoblastoma treatment and care under one roof. And moreover, these multidisciplinary centers may be located far off, as a result of which the children may need to travel long distances to access specialized care, particularly in low to middle income countries, where families struggle to pay for expensive diagnostic tests. Financial constraints represent a major barrier in retinoblastoma care, particularly in low and middle income countries. Chemotherapy and radiation therapy are expensive, and many families lack resources to pay for them. The cost of care also include travel expenses for patient and their families, their accommodation and other living expenses. The costs quickly add up for families who live in rural or remote areas and need to travel long distances. Cultural barriers also are barriers in retinoblastoma care. And in many regions and rural areas, there are traditional and alternative medicine practices are preferred. Families may not trust or understand the benefits of modern medical care. In families, cultural and religious beliefs may influence decision making. Peer pressure from the extended family members are there in Indian joint family system. And there's a gender bias against girl child on receiving cancer care. Overall, we can see that gender disparities have been reported in pediatric cancer care. And this study is from the Tata Memorial Hospital, Mumbai, and they have found a persistent gender gap between male and female pediatric patients. You can see over the 3 years, they have seen there's a persistent gap. And the worldwide ratio is 1.37:1. So expecting more than this from India, it should be somewhere nearby. But however, this ICMR data shows that the gender gap is quite a bit in India. And the reason is there is a prevailing trend even today in large parts of India to not bring a girl child with cancer for treatment to cancer centers. When resources are limited, generally boys are given preference and considered more precious. In this, with regard to retinoblastoma, there's an international study, and this is from the 153 countries, and they have found a significant gender bias difference only in India. Though it's there, a high male to female ratio seen in Asian countries, India in specific may have had an impact on global level analysis. It is likely due to gender discrimination and access to care in these countries rather than biological difference. Treatment abandonment is another big problem which is faced in managing these patients. The compliance rate has been reported from New Delhi, Lucknow, and Saudi Arabia to the from 67 to 86%. And here are the reference over here. And the causes of abandonment from Lucknow have been reported as rural background, financial constraint, hesitancy to enucleate, loss of pay and expenses on food, faith healing, and alternative medicine. So the reason from this Lucknow study says that once they refuse initial treatment and they come for retreatment, the mortality is high. And those who do not take treatment, the mortality is really high, 73%. At our institute, the treatment abandonment for retinoblastoma has been found to be greater for patients with RB versus other malignancies. You can see it is 28%. So in our study, we found that the financial limitation was a big factor. Concern for enucleation was 63%, out of which hesitancy for enucleation was seen more in for the girl child. And other difficulties were attending, various OPDs, and mortality was 68% in those patients who were non-compliant to treatment. Now, prevalence of complementary and alternative medicine has been reported, and this is a meta-analysis of 28 studies, and there is a considerable heterogeneity, and it ranges from 6 to 91%, and the remedies used are herbal remedies, diets, faith healing, and the reasons given are to cure, give relief, and support conventional therapy. However, it has been found that there was little evidence of an association between alternative medicine and patients' socio-demographic characteristics. The solutions are education and awareness. Much has been discussed on it, and this is to get early detection of cases. And the solutions would be a pilot project on community level involving healthcare workers, preschool teachers, parents with children less than 5 years old, and educating about all aspects of the disease, including genetic testing. Arranging group meetings, posters, flyers, and video demonstrations in cooperation with immunization and school eye health programs, and very important, teaching about proper referral. So all these will go in a long way to help the parents in managing child's condition, prevent delay in seeking treatment, and planning future. So easing financial difficulties can be by having a family medical insurance, free treatment of all cancer children. And in India, we have this Ayushman Bharat Yojana for low-income families. Create public awareness of government schemes. I think many people do not know about these schemes, and they just struggle to arrange for funds. They should be informed about the state government cancer funds and transport concessions which they get. And each institute has a poor patients fund, and this is from private donations which is used for the poor patients treatment. Then their NGOs play a big role. We have three main prominent ones, and we have this NGO called Can Kids, and they do a whole lot of services. Also, they have ensured accommodation home away from home so that the parents can stay there in hygienic conditions. And they do a lot of guiding and guiding parents for rehabilitation and arranging for prosthesis, etc. Tackling abandonment, preventive strategies has to be intensified and focus initial counseling tailored to stage of the disease. It has been found where they do intensive counseling, the abandonment rate is less. Then demonstrating good cosmesis for the concerns, enucleation concerns, addressing economic and social issues, updating telephone records and contact tracing, involvement of women's empowerment group to spread awareness and tackle gender bias. I think this has not been dwelt into, but I think this can be utilized. To conclude, I would say that existing studies and current flurry of published literature in reputed journals, they indicate towards multifactorial barriers in RB healthcare. Given that RB is a curable disease, available facts are worrying and mandate intervention at national and international levels. Understanding and addressing these barriers is crucial to improve the quality of care for children with RB and their families. Education to create awareness, removing gender bias and easing financial constraints will go a long way in effective treatment of these patients and preventing abandonment. Training programs and WHO global initiative to increase survival to 60% in childhood cancer are steps forward, which will include retinoblastoma. Research is required to study the aggressiveness of the disease independent of the age factor, especially in lower middle income countries, and develop innovative strategies to overcome them. Thank you very much for the patient hearing.
Thank you, Dr. Usha. That was really an eye-opener. And, you've beautifully touched upon very important issues that we face in our day-to-day care of retinoblastoma. And I'm sure Dr. Praveen, as a public health expert, would be the right person to guide us as to how we can overcome these barriers, because clearly it seems that raising awareness is not just the only issue that we have at hand. We also need to, develop strategies that can help us. For instance, like you mentioned, the girl child, abandonment of treatment, and all these things. So separate strategies will have to be put in place to be able to overcome these barriers, to improve our quality of care. Do we have Dr. Manav Jyoti here? He is from Guwahati. So I just wanted him to come in and let us know about what the situation is in Guwahati with regard to, these kind of compliance issues and traveling long distances and all that he faces in his practice.
And Bhavna, Manav Jyoti is there. Manav Jyoti, in the meantime, I just want to say, I don't know whether you have all seen the Marathi movie on retinoblastoma. I forgot the name of the movie. Have you seen?
Swas,
yes. So I'm saying, that was, I remember somebody carried that movie to Brenda Gale for showing, and one of her fellow came and did a veterinary fellowship, and now I think she's in UK. Anyhow, Dr. Manav Jyoti, I think, Dr. Manav Jyoti, you are now part of our BIRAC. We can do something like that, similar, Dr. Bhavna. We have 6 centers in BIRAC. We have got 10 crores from Government of India for creating registry for retinal diseases, but we don't have retinoblastoma there. Now, March 2nd, 3rd, we are having a meeting in Cochin where I am producing a topic on inherited retinal degeneration. Maybe you can write similar program where Manav Jyoti can take a lead. He was telling me when I was together with him in some meeting, I forgot now, I was traveling with him. So maybe we should do that with the Government of India has got about 1,000 crores and 10 crore they can give for the people who are here, who are doing the retinoblastoma work.
Certainly,
yes, sir.
That's a great idea. Dr. Manav Jyoti, so we are waiting for your comments.
Yes, madam. Kindly repeat the question, madam.
So you work and practice in Guwahati. So we were just, as a group interested in knowing, like Dr. Usha mentioned, so many barriers to retinoblastoma. What has been your experience, like in terms of compliance and, abandonment of treatment, or, the attitude towards the girl child?
Yeah, definitely. Northeast is a bit different in geographical area, and most common barrier we are finding here is the geographical barrier is the most important, along with economic. Definitely, it is prevalent. But in Northeast, most of the places are very hilly areas, and communication is a major issue here, along with the economic conditions also. So most of the patients, they find difficulty in traveling from this one place to another. So most of the central capital cities are connected well, but peripheries are very poorly connected. Connectivity is there. So many of the patients either we receive very late, or some are missed because of traveling issue from the parent side. So otherwise the things are similar to other conditions, other parts of the country. and definitely economy factor is there.
Yeah, definitely. One thing that I have observed is that, at least in RP Center, my experience has been for last 20 years, is that, we get children from the poorer segment of the society, with retinoblastoma. We don't somehow get many rich children. I don't know what has been the experience of people working in the corporate sector who can afford treatment. Puneet, would you like to come in and comment on that?
Hi, am I audible?
Yeah.
I'm sorry, because of my poor internet connection, I have to keep my video off so that I'm audible. A very good evening to everyone. So I've been listening through excellent talks, one after the other. A lot of perspective shared here. So the thing is that the corporate scenario is no different. The initial movement of the patient once he or one of the child is diagnosed with retinoblastoma is to go south. So even now, if somebody is diagnosed with retinoblastoma, let's say in New Delhi, their first go-to option would be Shankar Nethralaya. So, am I audible?
I think that is so. Is it that because you're referring them to particular places, you're not giving them the option, or is it because they feel that they can afford treatment? Dr. Usha, you've been working in Chandigarh, ma'am, and in PGI, which is similar to this. So what is the profile of cases that you see?
We have about 1/3 of the patients would belong to who are officially declared poor free by our patients. But then there are others who initially agree, but then they lose out on funds during the long course of treatment, and they would require some kind of help from the NGOs. So let's say 1/3 are poor, then others who would require financial aid during the course of treatment. So that would be quite significant amount.
Dr. Sunil, what is the situation like in Bihar? Do you have children from rich families being diagnosed with retinoblastoma as much as from the poorer families?
Most of the children are from poor socio-economic group, and before coming to us, they come to go to the peripheral doctors. Most of them, they do not know about retinoblastoma. They come in a later state. So that is why, Bhavna, with that is society, we can make people more and more aware, and like sensitizing the pediatrician or the ASHA workers or the Mamta workers or GP or us general ophthalmologists. So this thing is very important, that since in Western countries, even patients with retinoblastoma, most of their lives and functions are same. But in India, and particularly in Bihar, there is no reference chain. The people, ophthalmologists, pediatrician, and the people and guardians are not aware about retinoblastoma. They don't even do a red reflex test. Like Praveen was saying, that during immunization, if everybody sees a red reflex test, or the patient when comes to a pediatrician, if they see a red reflex test that there is no retinoblastoma, it will be of a great help. So sensitizing people. Otherwise, situation in Bihar is not very good. But I don't want to paint a big negative picture about it. But then yes, after awareness and all, Bihar, the health workers in Bihar are very aware, very laborious. So if they are not aware about this thing, the situation might improve with Bihar. Yes, Bob.
Okay. So
I would.
Yeah. Yes, please.
Yeah, post-COVID, what I have been seeing in Delhi is, in fact, patients are coming from Tajikistan, from Arabian countries, from Gulf countries with retinoblastomas to our place. This is what we have seen.
Right. So, very interesting talks we had today, and a very robust and exciting discussion. And before I, invite Dr. Natarajan for the concluding remarks, if anybody would like to comment or share anything at this stage of the webinar.
Yeah, Dr. Bhavna, I would like to. This is a suggestion to Dr. Praveen Vashisht. What we have seen that use of mobile phone has rampant, and it has even reached the remote areas of our country. So can we have just an information poster saying that any white reflex below 5 years could be retinoblastoma? Get your eyes checked. So Dr. Praveen.
Yeah, sure, ma'am. In fact, a poster campaign, which we mentioned initially, is one of the strategies, specifically in the immunization clinics. And of course, now we have a like using mobile phones, and everywhere is using WhatsApp. This can also be a strategy that creating awareness through a poster, a simple poster with 1 or 2 message that should be sufficient. And
Very simple, very short,
definitely.
and just to circulate through the mobile phone, through WhatsApp, and it would reach almost every corner then.
Right.
So, Professor Natarajan, so as President of ICANN India, what do you see like as the goals of the society, and how would we, achieve our mission? Natarajan, sir, are you hearing? Are you there? He's probably muted and he can't hear us. So, Natarajan, sir, I think he's probably lost us.
He's muted, ma'am. I'm asking to unmute.
Yeah, if you can ask him, because I would just like to, conclude with his remarks and comments. So the interesting good thing is that, we cannot see the participants, we can only see the panelists and speakers, but the feedback that I've got is that more than 500 people have joined us on the social media, and that is very encouraging for everyone out here, that we have people who are interested in the cause, and that also gives us, reason to continue with these kind of programs, and sort of a united effort to fight against this battle. So, Professor Natarajan, sir, can you hear me?
Yeah, I can hear you. Yes.
As President of ICANN India, we have people from different parts of India, experts from all over the country, and they have shared, their views and their experience with us. So how do you think from now on, how should ICANN India proceed, so that we are able to achieve some of the goals and targets that we have set ahead for us?
So we have these 5 zones. We should do a physical meeting with 5 zones with either chairman ARC or a part of the scientific committee, whatever you want. We use the AOS because AOS is our parent body. And I think AOS has got a rule, if you have 200 members, you can be officially affiliated with AOS, so you'll have a representation, which you should do. So everything is needed for advocacy. So my suggestion is to have a 5 physical meeting. I'm sure all cannot go, but Bhavna, like I traveled when I was president, now as a secretary, you can travel all over, because you have a lot of leave and a lot of official duty as a AIMS professor to do, and Usha will assist you. Both the Ushas. Traveling.
So I think we can propose the next physical meeting in Delhi, and giving enough advance and notice to everybody so they can make their travel plans and make themselves available. And then we can probably engage, being in Delhi, having the meeting here will also have the advantage that we can probably engage, people from the government sector who can play a crucial role in promoting awareness and, helping us achieve our goals. So with that, I would really...
And second is all the state societies, whoever the oncologists, ocular oncologists are there, should ask for a session. I know they may resist because everybody is asking, because that's what I did as an ocular trauma society president. And I think Vijay is always there. So Mahesh is part of the VRSI. He can also have a session in VRSI because he is the scientific chair. And I think a community of ophthalmology, also Praveen is there, where you should have a session. So ICANN India should have a session everywhere. It's not, we are not asking for name, fame, and money here. We are, I think, trying to create awareness. As Mahesh said, our own ophthalmologists are not seeing the eye and the patient as a whole. And that's what I think I learned from Dr. Bajanath, where you don't see the eye and you don't see only the retina. They even don't see the retina specialists don't see the optic nerve itself. Can you believe?
Really?
And they don't see the lid, they don't see the cornea.
Yeah, so coming to state societies, we have a very active member of DOS, Dr. Arun Baweja here. So do you think that we can ask DOS also for a session?
There's no thinking. You ask for it and take it. There's no thinking. But Arun has to barge in. No, seriously.
advocate for it.
You have to be bold, be strong, stand up. That's what some
We have to grab it, right? So we have to grab it. Right?
I think we should have a physical meeting in the midterm dose. So.
No, not midterm dose. We should
now
have
regular dose is coming, no? April. Or when is the regular dose? I forgot.
It's supposed to come in April, but we don't know yet.
Okay. Yeah.
So anyway.
But I think the thing will be to have even public meetings. See, I remember when I started genetics, public meetings where you can, it's not easy to give a talk to public because one, they should not be scared, but at the same time you have to create awareness, particularly on the masquerade syndrome and squint and how it can mask. They should not be scared, but at the same time awareness. And also programs in Doordarshan and in radios also. See, wherever without spending money, whether we can create awareness. According to me, Ratan Tata is a good friend. Now he's too old. He is making 100 cancer hospitals in India. And plus, I also want to do something exclusive eye cancer institute in Bombay, which I'm struggling. I'm not an oncologist, but and I don't like children suffering with retinoblastoma. So that's the reason. And unfortunately, the poorer section of Mumbai, particularly, I don't know why, the Muslim community has a lot of retinoblastoma. And they all go to, I think, I don't want to tell the name of the hospital, they go to government hospital and get enucleation done, which I feel bad. So we have to create awareness and do something. So I think all of us have to do. And I can see Usha, I see Mother Aurobindo in her.
I agree with Natarajan sir. Just when so we should involve as much of as general ophthalmologists to this forum.
Yeah, that's why I'm saying all sessions, no? All the state conferences, national conference, and public meetings. Definitely, general ophthalmologists have to be aware. No?
Yes,
They are not aware of the latest treatments available in retinoblastoma. They only know enucleation, I think.
Yeah,
whatever they studied in MS and then they answered an examiner, that's all they know. I mean, a lot of things what Mahesh has done, and I think Mahesh, your PhD is on retinoblastoma, right?
Right, sir.
Yeah, so we have a PhD in retinoblastoma.
So excellent. So thank you all for joining us this bright, beautiful Saturday afternoon in New Delhi. I don't know how the weather is in other parts of the country, but here it's really nice and sunny. So I leave you with a lot of food for thought over the weekend. Let's think about how we can come together, how we can, develop strategies, and hopefully, 5 years from now, we will be, presenting a different scenario of retinoblastoma in India. Thank you, Dr. Ashwin. Thank you, all our distinguished speakers and panelists. It was wonderful having you, and we will stay in touch.
Your Facebook Live is a great idea. You can keep, I just forwarded it in my post. I have only about 6,000 followers. So I hope.
Wow. So, yeah, and also a very big thanks to Entold, because they have supported this program, this webinar. It would not have been possible without their support. So very grateful to them for giving us this platform and bringing us all together to fight this cause. Thank you. Have a wonderful afternoon.
Thank you, madam.
Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Thank you so much. Thank you.